Ladies and gentlemen, healthcare experts, welcome back to Project Hospital. That's right, my name of course is OUTBREAK. We've got the brand new Infectious Diseases DLC installed. The music is working, which is always nice. Thanks as ever to all of the fantastic comments in the comment section of the last video. Very, very much appreciated. A couple of things that we want to clear up straight away. First of all, unfortunately, I don't think that there is any way to change, you know, pharmacists' lunch breaks. I just think that they take their lunch whenever they want to, and it's kind of irritating. But it is what it is. We're in the middle of an event at the moment. We've got an emergency style event. I can't even remember what type of event it actually is. Is it a car crash? Is it an epidemic? Is it an outbreak? Is it a natural disaster? I guess we'll just have to wait and see what some of these diseases are as they come through. Anyway, we got a lot of people coming into the reception, which is always great. What do we want to accomplish over the course of this episode? Well, again, reading the comments of the last couple of videos, I was kind of just perusing really and getting a feel for what you guys think that we should be doing here. Now, a lot of your experiences seem to be, hey, Potato, you need just so many flippin' x-ray machines, so many medical labs, so many CT scans, so many CAG scans, so many bits and bobs. So many bits and bobs from both radiology and medical labs that it sort of got me thinking, what do we want to do with radiology? I mean, we've got radiology down on the bottom floor here, and to be honest, I thought that this would be enough. I thought that these 1, 2, 3, 4, 5, 6 rooms, 2, 4, 6, yeah, 6 rooms. I thought that those 6 rooms of radiology capacity would be enough, but no, they weren't, and that's exactly why we built 1, 2, 3, 4, 5 more radiology rooms with a whole bunch of equipment and whatnot in here. But then it sort of occurred to me, that's not even enough. You know, we're having radiology capacity issues at differing points, and we haven't seen it this episode yet, but we almost certainly will see it at some point over the course of this episode. Also, look at the sheer number of patients that we have coming into the clinic here. Do I want to get some more doctor's offices? I could get some more night doctor's offices. I'll hire some excellent night interns. Sounds very dodgy, but it's not. I can assure you. So we'll get that sorted, see if that makes any difference, because we're not anywhere near the night, but that's okay. We are full of patients in all of our trauma centers. How is that physically possible? I genuinely do not understand that, because you should be diagnosed. You should definitely be diagnosed. Is there... What the heck? All of these doctors are just idle? All of the doctors are idle? Oh, you're dead. Oh, you're dead. Oh, that's not curable. That's not curable. Let's get you moved manually. Let's get you moved. Yeah, these are both general surgery issues. Let's get you. You're already being moved. Okay, cool. Right. Yeah, sorry. We got a death here. That's a little bit less than optimal, I would say. Yeah. Yikes. There we go. Okay. That's a little bit better. How are we doing ambulance-wise? You can tell how we're doing ambulance-wise if you have a little look at the number of ambulances that we actually have in the parking lot. So we've got 3 in the parking lot, which means that there are 2 out on their rounds. So we should be seeing 2 more arrive in pretty quick succession, actually. But that is completely fine. Yeah, it's just not going well. It's just not going well. The event, I mean, we've diagnosed almost everyone. We've got 3 more diagnoses to make. We've cured 30% of people. I think that we've got another sort of half a day to be able to nail this. You're going to the lab. You're going to the chair. I mean, I will try and treat you with, like, critical care, but unfortunately, I don't really know if that's going to speed up anything, frankly. We'll have to wait and see. I've had a bad experience. I've had a bad experience with treating patients this critically before. But maybe, just maybe that'll change. Yeah, anyway, I feel like we're super close to having, like, a really, really, really optimal hospital setup. But we just need something more. Anyway, returning to the whole vein of thought that I was chatting about earlier. Radiology. Radiology, radiology, radiology. I almost feel like we could really benefit from just having, like, a bespoke radiology level. I mean, well, maybe this level, actually. Maybe this level. Maybe this level up here. It's occupied by admin services at this moment in time, which is okay, but I mean, admin services probably isn't really going to expand much past this size. It would be kind of weird bringing patients up to the morgue level, the same level as the morgue. But is that really something that I care about? Not really. I don't think at all. I do think that we need to expand dramatically our radiology capacity, and I think that the only way that we do that is we devote an entire floor to it. We devote an entire floor to radiology. The only problem with radiology, the only problem with radiology is that it is singularly the most expensive department to build. The most expensive department to build by a wide margin. Also, how are we just not being able to treat these people? Michael Johnson, you again are presumably waiting for... Yeah, you're presumably waiting for a whole bunch of tests to come back. Brooke Wright, you're still waiting for a test to come back. I mean, how is it possible? How is it possible to still have your... There we go. Okay, influenza. There you go. We got you diagnosed with influenza. We'll give you antivirals. There you go. Diagnosed. Easy. Easy peasy lemon squeezy. I mean, maybe I should be taking control of these patients and doing it manually so that I can investigate exactly what the situation is. So that they don't have to go to terrible doctors. Also, that's another thing. Maybe we just want better quality doctors. Maybe that's what we have to do. Maybe we just, you know, we take it easy on a couple of days and we get our doctors all trained up. We get them into the advanced diagnosis class or something, you know? We do something like that. Okay, I'm going to give you a differential diagnosis as well. See if we can figure it out. I'd love to do a differential diagnosis on you, although that's not possible. There's no clear diagnosis for you. Ambiguous results. What the heck does that mean? Okay, let's regularly hospitalize you, and then we'll do tonometry. Where is that prescribed? Neuro exam unit? Okay, so clearly you've got an issue with the brain. So let's move you to the brain department, shall we? There's no clear diagnosis. Yeah, that's why I... Look, just do some examinations. Don't do an angiogram. That's not what we need. We don't need that at all. Just give you an eye exam or whatever. That's fine. Okay, we've cured 60% of patients. This is irritating because, you know, we have the capacity to do more than this. Yep, we need to do that. Do you require hospitalization for that? I'm gonna hospitalize you just in case we need to deal with that. The results for the medical labs tests are just taking like a billion years, and I have absolutely no idea how we can accelerate this further. I mean, we have got so many. We've got so many rooms. We've got so many rooms, and you'd think after half a day of faffing around with this guy's test results that they'd be done. But no, apparently not. And if we're not finished with these test results quickly, we're gonna fail the event. It's literally just that simple. It's just that simple. Okay, so we're still waiting for test results for you as well. And you're a high quality, high priority patient. And I'm flipping trying my best here. I think we're about to fail. I don't know if this countdown timer is gonna announce us failing, but yeah, I'm not surprised by that. So. Oh no, we've got a flippin' epidemic. Who infected the hospital? Oh, you gosh darn fools. I don't believe it. Okay, well, everyone is going to be upset for like 2 days, which is just awful, just absolutely dreadful, just the worst. frankly. I'm just miffed off at my whole flippin' medical labs department. That's another department that doesn't know how lucky it is, frankly. I have worked my backside off to make sure that the medical labs department is as big as it is. And it's just not working. It's just not working, Governor. It's just not working. Okay, here's what we're gonna do. Here's what we're gonna do. There's no free bed in isolation hospitalization. That's not... You don't need to be in isolation hospitalization. Who put you in isolation hospitalization? Jane? I hope it wasn't you. This is not a contagious thing. Right. I'll be upset about that in my own time. Thank you very much. Patient is about to leave the clinic. Hospitalize him. Hospitalize him. What's the worst that can happen? What's the flippin' worst that can happen? You end up, you know, creating an outbreak in the hospital? No worries. There's already been an outbreak in the hospital. Don't even concern yourself. Don't even concern yourself even slightly. Renal vascular surgery, or your staff has been busy for a long time. Cardiology. Wow, cardiology is just an awful unit. And oncology. No, not oncology. Orthopedics. Oncology is cancer, which is not what we're dealing with here. But the bone department is my favorite department. The bone department is good. We've also set cardiology up to work, right? You know, so why are we not having much luck over here? You're idle. You're idle too. Performing renal surgery, renal vascular surgery. Yeah, that's good. No free bed in isolation hospitalization. Oh, that is highly contagious. Yeah, that's a problem. You know what? You can just chill out here for a while. Don't even worry about it. Just chillax a little bit. Yeah, my surgery teams are not very committed to doing surgery, are they? I feel like they're very relaxed about this whole idea of doing surgery. Carol Thomas, you're not even bothered. You're not even bothered. I mean, we've got loads of people to do surgery on, but we're just not doing it. Casey, you're idle as well. You're the anesthetist on call at this moment in time, and you're not bothered about it even slightly. So, I mean, what can I say? I'm just grumpy. I'm just upset. Look, the thing that you got to realize is that the more surgeries we do, oh no, there was an incorrect diagnosis. Who incorrectly diagnosed you? But we've given you fracture arm surgery, right? Yeah, we've given you fracture arm surgery. Have we repaired the right arm? Yeah, okay, we needed to give you fracture arm surgery anyway. So frankly, it didn't matter what your diagnosis was. We had to give you the same surgery anyway. So how is it that the bone department is able to keep up even though they don't have a dedicated surgery team? Sure, treat you at high priority. See if that makes a difference. I don't know if treating people at high priority actually does make a difference. Aha! Ahaha! Cardiology has suddenly started doing operations again. Brilliant. Okay, so it does happen. It just takes a little while for the video game to figure out when it wants to do the surgeries. I guess that kind of makes sense. We do have like 400 staff, so this is quite a lot of stuff to deal with. I guess it does make sense. Okay, we've had 4 people leave already. And that's mostly because we just haven't been able to do these really expensive operations. Which is kind of ridiculous. There's no free bed at observation. That's okay. We're just about at 8 o'clock in the morning, which is going to free up a whole bunch of capacity. I feel like maybe the answer to this is just we need more doctors. We need more doctors pretty much everywhere. Doctors that are surgery capable, doctors that are able to diagnose patients. Just more and more doctors. That is what I feel like we need. Patient died. Yeah, okay, we'll send you up to autopsy. I'm not happy about it. I'm not happy about it at all. You're still dead? Okay, I'm gonna send you home. That's ridiculous. So one of our trauma centers was just taken up with a dead body for, frankly, days. That is ridiculous. Okay, well, it's at 8 o'clock in the morning, we end up making about 50 grand, which is very good. Very nice indeed. Like, that is a lot of money. In fact, it's more than 50 grand, actually. It's an obscenely large amount of money. Yeah, so we just made about 60 grand. Holy cow. Yeah. Wowzers, that's real good. That is real good. But still, we still have the issues. We still have the issues that we have with testing. Now, there are a couple of things that I can do to just ease this a little bit. So what I've done over here, and what I think I'm gonna do again, actually, give me a blueprint just for a second here. There we go. Copy, paste. Oh, no. Paste in there. Paste in there. Paste in there. And paste in there. And that's good, right? Now we still need to get stools for these places, and we still need to trash the bins here. I can do that with this tool. There we go. So trash that bin right there. Trash that bin right there. Trash that bin. And trash that bin. Then we go and we grab ourselves a stool. Excellent. Stool. Brilliant. So this should just increase the number of technologists that we're able to get at... There we go. At every single medical labs building, right? And so that should theoretically just allow us to process a few more samples. Oh, I don't have night people working in this lab apparently. That's okay. Either way, medical labs is a bit of a joke. It's a bit of a joke. It's a bit of a mess. Everyone needs a flippin' test of some sort in order to diagnose them, which is inconvenient to say the least, frankly. Very, very, very inconvenient. Okay, so I don't want to say that we've just doubled the number of employees that we have, but we've done close to doubled actually. We've done a good job. We've done a good job there. Pretty happy with that. Okay, we did have to take out a little bit of a loan, but you know, good things come in small packages. My loans come in large packages, therefore it must be a bad thing. No, wait, don't use that logic. That's backwards logic. Twisted backwards logic. The department cannot run any more tests. I mean, you've probably got... Oh, you're an expensive case as well. Look at your insurance company's overcure. I mean, you've probably got something internal medicine related, so let's move you to internal medicine related, shall we? Yeah. I also should have a little look at the department stats just a little bit more regularly. So, for example, patients on clinic, yeah, we're fine. We're fine here. Radiology, yeah, workload during the day, critical. We know this. Medical labs is not actually technically critical, but that's okay. ICU is not critical. General surgery. We don't actually have any patients. We don't actually have any patients at the HDU bed. What the heck? How are you dying? All right, just send you home. We don't really have the capacity to do autopsies at this moment in time. We don't have a single patient in an HDU bed. Is this bed capacity or is this patients at regular ward? But wait, we do have people. We do have people in we do have people in the HDU ward though. Wait, so are there 15 patients that need to be in high dependency that don't have space here? Is that what you're telling me, video game? This is somewhat of a difficult thing to understand. Hold on. Is this general surgery? No, this is general surgery here. Okay, I was on the wrong floor. That would be a good step in the right direction. Okay, yeah, it turns out that our general surgery department is empty. Literally empty. We have 3 patients. That's it. We have literally got 3 patients at the general surgery department. What the heck? Internal medicine. Okay, internal medicine, we have like a chronic lack of beds, I think. That might be somewhat of the problem. We've only got like 12 beds there in total. Same with orthopedics. We only have 8 beds there in total. That's abysmal. We've got a few more at cardiology. We've got one room that's in critical usage at cardiology during the day. I mean, what is it? What is the room? Is it the... It's not the operating room. It's the diagnostic unit. Okay, so the diagnostic unit in cardiology is busy. It's real busy. Okay, I mean, this might be a good thing. This might be a good thing to see if we can try and get some more of. As I say, like, I feel like we're almost there. It just takes a little bit of time to get us across the line. Okay, so grab another diagnostic unit. Give me... I guess we can put a diagnostic unit, a slightly larger diagnostic unit in here. That's fine. Pretty cheap, actually. 4 and a bit grand. That's completely reasonable. So that's 2 additional diagnostic units, and presumably it's the same... Presumably it's the same unit that's, yeah, critical during the day and critical during the night. Okay, bed capacity here is fine. Bed capacity in internal medicine and the bone department both need to be adjusted, but that's fine. We'll get to that later. Neurology is up a floor. Let's head up here. You know what? We need some more regular... We need some more regular wards. I feel like I just need more beds now, right? Maybe if I just get more beds, everything will just run smoother. Famous last words, etc. But, you know. Okay. So that should fix us up. What about the infectious diseases department? How are we looking there? Nurse's room is critical at this moment in time. What has a critical workload? It's the diagnostic unit again that has got critical workload. I did sort of briefly think of addressing this issue and then immediately thought otherwise of addressing this issue. Because I don't really like the way that I've got the department laid out at the moment. To be honest, I think maybe the answer is closing off this ward here. Yeah, okay, here's what I'm going to do. This is the plan. We're going to build a brand new infectious diseases regular ward. Right? Just a brand new regular ward. 12. Yep, perfect. That size. Right in there. Wonderful. Excellent. That's fine. That goes in there. Walls up. Walls down. Zone is a corridor. Easy peasy, right? Okay. Then what we're going to do is we're going to head downstairs. We're going to de-zone this as a regular ward, which is going to cause like 4 patients to be moved or whatever. And then we're going to actually just rezone it as a diagnostic unit or 2. We're actually going to say this area from here on is all... This is all an area that you need to wear a mask. Very, very important that that's the case. Okay, then we go bulldoze all of the objects in this room. There are still technically patients that still occupy this bed, but that's completely fine. Patient is waiting for a room transfer. Yeah, I know. Patient died. Internal medicine is a kicker. Wow, okay. Let's get you moved up to autopsy, but I'm actually just going to send you home because our morgue department is full. I tell you what, I should address that, like, literally right now so that we can continue to make money from the dead. Very, very important. Okay. Yeah, what do we got? What do we got in the pathology department? I keep saying oncology. I really don't want to. You, autopsy. You, Thomas Smith. Are you the same person? Fraser Jones, Thomas Smith. No, they've just got very, very similar looking features. Okay. Patient is waiting for a room transfer. Yeah, if I click on you, if I go to you, we'll see you get transferred in just a second. Don't worry, the transfer is coming. Excellent. And then that means that we're just down to one last final bed. Sell that bed, sell that bed. And I have no idea the person that's currently occupying this bed here. Okay, or maybe there's nobody occupying this bed. Okay, alright. Well, you know what? Frankly, that doesn't matter at this moment in time. What does matter is that we get an infectious diseases diagnostic unit, 6x6. It's just a ticket. Just the ticket right in there. Thank you very much. And we're going to get another diagnostic department right in here. As soon as we're allowed to do such a thing. There we go. Patient is waiting for a new room transfer. That's fine. That should be just coming. There we go. You're out of here. Brilliant. Let's demolish that bed. Brilliant. And then we go into building. We get a diagnostic unit. Excellent. And then we're going to get rid of that weird door, which is still there. Both of them. Yeah, excellent. Okay, so 2 additional diagnostic units. That should really, really, really take the edge off. Yeah, that really should make a big old difference. Let's go back up to internal medicine. Let's go back up to internal medicine. Internal medicine, I think I commented on, has only got like, yeah, it's got a paltry number of beds. Also got a severe lack of nurses at this moment in time. I'm gonna buy some new bedrooms up here, right? We're gonna buy a brand new regular ward. Brand new regular ward. Brand new high dependency unit. They actually cost like, I don't know, relatively little. Relatively little in the grand scheme of things, but still, I mean, a fair amount of money when you're as much in debt as I am, but let's just make sure that internal medicine is up to snuff. Because it doesn't feel up to snuff at this moment in time. Okay, you know what? Give me a specialist. Give me a specialist. Give me the most expensive people. Give me some more janitors up here. There we go. There we go. Wonderful. We don't have any capacity issues at the clinic, but we do have a lot of blood issues. Yeah, that's frankly a disaster. An absolute disaster. I don't think that we have any issues with like there's no free beds at trauma center hospitalization. Autopsy finished. Yep, you should immediately be sent home. Brilliant. 5,500 bucks we could have made from you. Oh, that's such a shame. Well, the good news is that I fixed my pathology department, which is great. Okay, how do we not have a single trauma center free? I think we do, actually. I think we do. I think that's us sorted things out here. Okay, that's good. That's a step in the right direction for sure. For sure. We got 1 day left on this horrible, horrible, horrible epidemic outbreak, which is just an irritation more than anything else at this moment in time. So that's kind of nice. Our radiology department still has like massive issues, I think, right? Yeah, 5 critical rooms during the day, 5 critical rooms, or 4 critical rooms during the night. It's just irritating. Irritating more than anything else. Also, I should have checked. Are there radiology... There is a radiology bathroom right there, yeah. I wonder if maybe we just need bathrooms, or more bathrooms just in general. People can queue up outside the bathroom. Like, that's not something that I'm against. Maybe not in an epidemic, but, you know, under normal circumstances, I think that that's completely reasonable. Autopsy is finished. Let's send you off to funeral services. Excellent. Okay, 11 patients leaving today is bad. It's really, really bad. Very, very bad. Not happy. Not happy about that even slightly. I don't need any more doctors. I don't need any more nurses in emergency. I'm maxed out. I really, really am. Yeah, we've only got a medium level of certainty for emergency, which is probably the way to go. Which is probably the way to go. I still feel like the difference between high certainty and medium certainty is actually quite important. Just gonna zone this as a corridor real quick. There we go. It's quite important, right? Because high certainty basically dictates that the doctors are going to order a bazillion tests. Okay, you know what? I think I'm prepared for this. There's a crash. There we go. We've only got like 8 patients or something. They're all going to come to the reception, I hope, or most of them are going to come to the reception. Nope, none of them are going to come to the reception. They're all going to come via ambulance, which is fine, actually, which is fine. We've got a couple of trauma centers ready on standby. Chest contusion or broken ribs. Oh, you're gonna have to get X-rayed, aren't you? I just know it. I just know it. I can feel it. Patient died. Okay, send you up for an autopsy. Oh, boy. Have we got any patients? Have we got any patients coming in? Sarah Williams? No, you're Carol Wilson. I don't think we've got any of the crash patients coming in quite yet. Thomas Lee? No, don't think so. Don't think we got any patients come in quite yet. A lot of them are still waiting for an ambulance. You're waiting for your cardiovascular surgery, but that's fine. Are you one of my patients? Rachel Jones. No, you've got a traumatic brain injury, and therefore you can actually be theoretically transferred like straight up to you know what? Yeah, transfer you straight up to brain place, to neurology. Mostly because it's pretty darn important that we clear these ambulances out so that they can get the crash people. Are there enough free nurses for transport? There should be. We should have no issues with nurse transports. We should have no issues with stretchers. The hospital is flipping crawling with stretchers. Absolutely crawling with stretchers. Okay, the pandemic has ended, which is great. You've got broken ribs, which is brilliant. Literally just compression wraps. Just compression wraps. Excellent. Okay, are you on my list? Susan Wilson. Yes, you are on my list. Brilliant. You've got a blunt spleen rupture, and you can be moved directly to where you need to go. Or alternatively, you could be moved there. There's a long wait for HDU hospitalization. I'm going to move you to ICU then, if that's the case. Yeah. Move you to ICU. It's pretty darn important that we get you seen to as quickly as we possibly can. Karen Davis, you're not on my list, I'm afraid. Sarah Williams, you're the one with broken ribs. You've been treated even though you're in the ICU, which means that you're going to be set to get on your way tomorrow. Excellent. Penetrating head trauma. That's going to require brain surgery, and it's going to require brain surgery, like, right now. Pretty much as soon as possible. Man, brain surgery's tough. The good news is that we're getting everyone in via ambulance fairly quickly. Patient died. You're not on my list, are you? No, you're not on my list. Thank goodness. Okay, it's not good to see a patient die just before we're supposedly doing a pretty complex event, but that's fine. Okay, you need to be treated. Critical care. You have had an operation done already. Yeah, you've straight up had abdominal surgery. That is excellent. Okay, it's weird because the general surgery department is just seemingly so empty. We've got, like, no one in here. We've got nobody in the flipping general surgery department, which means that when surgery, abdominal surgery, are you on my list? No. But you will be treated. You will be treated fairly soon. You can't just skip abdominal surgery. No. We'll redo that. That's fine. There we go. Yeah. It's weird. So, like, when somebody comes to the general surgery department, they're actually treated, like, fairly quickly in comparison to normal. No, you're not on my list. I just need to make sure. I just need to make sure that nobody on my list ends up going under. Traumatic brain injury. Can I make sure that you're treated? Can I make sure that everyone is treated here? Waiting for a bed. You're waiting for a bed at HDU. At the bone department. Ah, okay. Bone department is a big old problem. Bone department is a big old problem. Let's go to bone department. Let's go to bone department right now. Is this bone department? I didn't guess lucky. Next one. No. Next one. Okay. Down. Okay. This is bone department. Excellent. So we need more beds. We need more normal beds. We need more high capacity, high dependency beds. We absolutely do. Okay. We're only going to be able to afford one. We've maxed out our loan. I'm terrified. Let's buy high dependency beds. Buy high dependency beds. 4 of them. Brilliant. Let's freaking go. Okay. I imagine that those beds are going to be allocated quite quickly. Knee sprain. Yeah, okay. You literally have a knee sprain? Is that it? Is that it? Okay, you're getting your fistula fixed, I think. Susan Wilson. Oh no, you've got the blunt spleen rupture. There's no morgue table for the recently deceased. That's okay. Let's go back up to the top floor. And we'll see if we can clear out some of these bodies. There we go. That's morbid, but needs to be done, right? How is it even possible that I'm failing these things? I feel like I'm throwing absolutely everything at the problem. I built more beds. I built more beds. I'm doing it. William, were you one of my issues? Is there a problem at neurology? Is there a problem at neurology? Is that what the issue is here? I feel like maybe we just need to operate now, ask questions later. Is that really what we need to do? I don't think that there's a bed shortage at... There's definitely not a bed shortage at neurology. How on earth did you manage to die? I have no idea. We just need to do it. Okay, you know what I'm gonna do as a knee-jerk reaction to this? I'm gonna set all departments to low level of treatment, right? I'm gonna set them all to low certainty, which means that as soon as they have a vague inkling of what the heck the patient has, they are either gonna operate, or they're gonna diagnose, or they're gonna do something, okay? Because I think that this might be where our problem is coming from. But frankly, it's a little bit ridiculous that we cannot specify exactly what doctors take into account or what they disregard. I mean, come on. I'm just looking for a regular, straight-up, simple diagnosis. I'm not looking for rocket science or brain surgery. Well, actually, tell a lie. I am looking for brain surgery in the neurology department. Right. Right. The pharmacy's too small, that's not an issue. I'm just in a state of aggravation at this moment in time. Not to mention the fact that my debt is completely out of whack. Right. We know what you've got here. We know what you've got. Low level of certainty. Low level of certainty. We want to treat absolutely everyone. Treat absolutely everyone. Doesn't matter. We'll treat them. We don't care what they've got. We don't care if anyone comes back with an incorrect diagnosis. Frankly, not my problem. If we operate incorrectly on certain people, as we have done in the past, frankly, not my problem. Not my issue even slightly. Patient is leaving. Why could you not... Oh, you can't... Okay, we need more regular beds in the bone department. That's fine, that's fine, that's fine. I'm taking a much more active approach to fixing our room issues. I feel like a lot of our issues perhaps stem from the fact that we just don't have enough rooms. And that's prohibiting us from doing a lot of surgeries. So whenever I see a room shortage or an issue that is caused by a room shortage, immediately, I'm going to try and fix that. I would also love to just complete an event successfully. That would be really, really nice. Just one event video game. Just not more than one. Just one. Just a single event. Collapsed patient is waiting for a bed. Trauma center hospitalization. We have 5 trauma centers. How do we not have more than one free at a time? That blows my noggin. That blows my mind. Blunt spleen rupture. General surgery, honestly, general surgery used to be so flippin' busy, but now it's just not. It's actually fine. You are also fine, that's okay. We have 422 staff. 422 staff, and we're not able to treat even 82 patients a day consistently. Long wait at the pharmacy? Get away, get away. Don't even want to talk about that. Send you home. Excellent. Again, the pharmacists are just, oh god, they're just dreadful. Long wait at the pharmacy. Okay, you know what? This isn't even going to become a pop-up. I don't even want to be notified. Leaving pharmacy, I don't even want to be notified. If you leave the pharmacy, then that's not my problem. That is frankly not my problem. Dialysis, long wait for treatment. Dialysis is done in a diagnostic unit at the general surgery department. What's the diagnoses on that? To be honest, it's probably just the fact that we haven't got round to it yet, more so than anything. I'm sure it'll be happening quite soon, actually. Yeah. Probably will be. Excellent. I wonder if we just need more cleaners, like, over the course of the entire hospital. But also, I'm just not overly bothered about it. Senior janitor, congratulations. That's excellent. I could assign you some rooms specifically, but I don't think that we really need to be honest. I don't think that we really need to do that at all. I don't think janitors need to be assigned specific locations. They seem to be doing a pretty decent job on the whole. I think it's just the number of janitors that we have is probably too small at this stage. If I go into general surgery, we've actually got 3 janitors here. 3 janitors during the day, 3 janitors during the night. We've got a lot. I wonder, maybe it's just the fact that I don't have enough doctors. Is that the issue? I can pay down some of my debt. I can at least try. Still don't think that we're going to run a true profit today, but we might run a fake profit. By fake profit, I mean, you know, variable costs. We might run a profit in variable costs. I mean, on the whole, it's not bad. It's not bad. Radiology, I think, is still bad if I have a little look at the radiology department. It should reduce, though, right? Okay, so it's 3 critical during the day, 4 critical during the night. I mean, that's fine. What about medical labs? Medical labs probably hardly has any usage at the moment because I've demanded that everyone diagnose on instinct. Yeah, look at that. Look at that. Medical labs practically empty. Practically empty of business. Can you believe it? I certainly cannot. To be honest, I feel like this is the way. We just leave it on low certainty and just hope that works. At the end of the day, right? If we end up misdiagnosing a patient or accidentally doing a surgery is a bit of a problem because it means that we have to pay 20 grand, which is a bit of a pain in the backside, right? I appreciate that. A bit of a pain in the backside. However, long wait for examination, long wait for an interview. Do we perhaps not have enough staff on general surgery? No, we do. We do have enough staff on general surgery. We do have plenty of staff on general surgery. Yeah, okay, all right, weird. Maybe we just don't have enough doctors in general. To be honest, that could very well be it. Patient died? How the heck did you die? Where are you? You're in intensive care over here? In intensive care? Okay, and you died... Oh, okay. All right, well, I guess we'll get you up to the pathology department as quickly as we possibly can. How's our prestige looking? It's looking battered. It's looking battered. It's looking bruised. It's looking, yeah. It's looking like it could be better. 70% at the end of the day. Am I still suffering from negative prestige due to the lack of successful completion of events? I suspect that might be the case. I would love to just complete an event. That would be brilliant. Long wait for examination, physical examination. You see, that's the thing, is that there are doctors that are chilling out here. I guess they're all preparing for surgery. You're preparing for surgery too? Are they where are they doing the surgery? Where are they doing the surgery? Hold up. The doctors who were here, like you, for example, you're performing... What the heck are you doing in this surgery room? This is on the heart floor. What on earth are you doing up here? Are you... Okay. What the heck? What the heck? Why is this the best surgery room? There are like 20 operating theaters to choose from. And you choose the one on this floor? This is probably quite a busy one. Apparently not a busy one. What there is one much closer to you on the... I just don't know. I don't know. Is it actually quicker for them to path into the elevator as opposed to just go to this? I have no idea. I have no idea. I have absolutely no idea. That is very, very strange. You're collapsing. Long wait for transport. Yeah, don't even worry about it. I'm worried about the patient that's collapsing. ICU hospitalization. Hold up. We can actually fix this. Who's in ICU at the moment that doesn't need to be here? Everyone is in ICU for a good reason. Nobody's dead. Oh. Hospitalized, sleeping. I mean, that's a bit of a pain in the backside, actually. That's a bit of a pain in the backside. We don't have any more money that we can perhaps build another ICU unit with. Okay, I'm afraid you're gonna have to be, you're gonna have to be moved to another hospital. It looks like we need 1 or 2 more ICU wards, and then that'll be us. But I'm not happy about that, actually. Monitored patient is collapsing. We have a lot of monitored patients that just happen to be collapsing. It would be great if that could not happen. All right, I guess we'll see. Maybe if we're lucky, we're able to make to make do with the number of ICU rooms at this moment in time. Although more probably, I'd like to build another couple as soon as I get my big paycheck at 8 a.m. Anyway, I'm hoping for a big day today. I'm hoping for a big, good, important, profitable day. Yeah, I also find it really, really strange how the patients all get better at 8 o'clock in the morning. Like, that leads to, like, chronic capacity issues. It really does. It really does lead to chronic capacity issues. Like, if you're better in the evening at 6 o'clock, what's wrong with going home at 6 o'clock? What is wrong with going home at 6 o'clock in the evening? Pharmacy's too small? No, it's just because I've got terrible pharmacists. Oh, no, apparently it's not. My pharmacists aren't even at fault on this specific occasion. As difficult as it is to believe. So everyone in the ICU should have gone home. Yeah, we've got 4 additional beds in the ICU. That's cool. Patient returns with an incorrect diagnosis. Again, I really feel like I want absolutely no notification about any of this. Patients that return with incorrect diagnosis, not even slightly concerning to me. They don't even register on the Richter scale. As my doctors get better, I'm just gonna hope that the number of incorrect diagnoses decreases. Hospitalized and collapsing. Yeah. There we go. Hospitalized and treated. Septic shock is suppressed. Okay, great. You should be fine, I think. Autopsy finished. You're gonna get sent home. Wonderful. Cool. Employee is leveled up. Brilliant. You are our surgeon, actually. Congratulations. That's really, really great. And your doctor's rating is pretty good. It's pretty good. I should probably look at that a little bit more. And then just fire some doctors who are, you know, who are terrible or who have a terrible doctor's rating. That would probably be a pretty decent idea. Make our hospital a little bit of a friendlier environment. Surely can't hurt. Well, maybe it hurt financially. I don't know. Either way, things ain't too bad. How's the radiology department doing in terms of criticality? Honestly, good. Much better. We've got 1 room that's critical. To be honest, that's probably a room that we don't have doubled up yet. Let me have a little look. CT scan. CT scan is critical during the day. CT scan is critical during the day. And is that it? Maybe that's it. It does say that we have 1 that's critical during the night. Yeah, okay. Apparently we only have 1 that is critical during the day. So, I mean, look. This is what you get. This is what you get, video game. You're asking me to treat the patients much worse. And I will do that. You know, I have no issues treating my patients worse. I mean, that's fine. If that's what you really want. I don't really think that it should be what the aim of the game is. I think that we should aspire to treat our patients slightly better. How many is this? 1, 2, 3. 1, 1, 2, 3, 1, 2, 3, 1, 7. Okay, so 7 little pips. So 1, 2, 3, 4, 5, 6. We need to go down 1 more. That's fine. Build foundations. So down to here. And then we go 1, 2, 3, 4 out this way. If I'm not mistaken. There we go. That's looking brilliant. Cool. Alright, so we throw this in here. Oh, we need 131 more bucks in order to be able to fund this ICU unit. Sounds kind of crazy, but it's true. Okay, this is going to take me well into negative cash flow territory. But it'll be worth it. I keep telling myself. Okay, I messed that little bit up, but that's fine. Right, 58 grand down the drain. Very, very, very much worth it, though, in terms of just getting 3 additional really, really, really important beds. Really, really, really important for us that we have more ICU capacity. Not over the moon about how much I had to spend, but that's okay. Alright, I think this is the way that our hospital just, like, increases the ability to treat patients. Do you know what would be really, really good? I really, really wish that I could set some sort of setting. So for diseases, or for possible outcomes that are not fatal, you know, like the common cold, stuff like that. I wish that I could just say, okay, you know, level of certainty that we need to treat, it's at low. But if there is perhaps like a more serious diagnosis in the mix, then let's say, okay, let's crank it up a little bit. Let's work a little bit harder to determine exactly what the issue is here, so that perhaps if there is a fatal symptom mixed in with what you've got, then we can discover it and we can get to it fairly quickly. Because at the moment, there is no differentiation between clinic diagnoses or ambulance diagnoses. I mean, I wish, for example, that I could set the ambulance or some sort of ambulance criteria to, like, high. It's like, i.e., we diagnose all of the symptoms from an ambulant patient. So, for example, you here. Mark, right, you've got 6 hidden symptoms, and no doubt some of those symptoms will be discovered by the doctor in the trauma center. I'm sure a couple of them will be emerging. But you've got a cerebral contusion. However, there is potentially a fatal symptom in there. If the eye is flashing, then that leads me to believe that there is a fatal symptom. On this occasion, the eye isn't flashing, but there you go. I suspect that the head trauma is probably what is, or the head injury, both of which can actually cause death. Although I think the fainting can cause death as well. Christopher Lee, where the heck are you? You died from heart failure. That sucks. That really, really sucks. That is the emergency department prestige that is going to be tanked. Yeah, that sucks pretty hard, actually. That sucks really, really, really hard. Okay, well, we'll get you moved to the pathology department, but it is what it is. Leg cast. It's taken a long time to get you casted up. Fine. I'm sure it'll happen at some point. Also, the changeover happens very, very abruptly. Everyone picks up their tools at 8 o'clock and just leaves. And that's still whilst everyone is walking in. It would be good if there was like a little bit of a handover time, as there is in real hospitals. You know, when everyone gets together, has a little briefing, and has a little discussion about what the issue is, etc. So yeah, that would be good. That would be really, really good. But alas, that is not a thing that is currently in the game. It's midnight. There we go. Okay, we're only 110,000 bucks in debt. And that is kind of crazy. Okay, 56 patients coming our way today. Only 56 patients. Everyone is leveling up, which is wonderful. Have profit 5 days in a row. Have I had profit 5 days in a row? I don't think I have. All right, you know what? Give me every single insurance objective. I mean, we can take them all. We can take them all. 134 patients. 134 patients. Give me what you got, video game. I'm the maddest of lads, but let's give this a shotty, shall we? I really do think that with a low level of treatment care, we can probably deal with a greater number than we would otherwise expect. Another part of the reason that I'm just accepting absolutely everyone is that, you know, my prestige is so low that I was only getting 56 patients from my usual allocation from the insurance companies. Crash on the stock exchange. Oh, yikes. Okay, so heart and brain attempts. Carol Lee. I'll get you autopsied. Fine. Also, something else that I should consider. Let me go up to pathology just for a second. Okay, pathology. We only have a nurse. We only have one nurse and a doctor during the day. However, I actually think that we've got enough deaths to warrant. We've got enough deaths to warrant a night pathologist now as well. So let's do that. Okay, anyway, how many people have we got coming in via ambulances here? Oh my goodness gracious me. Okay, we got a lot of patients coming in. I think that we might be able to get away with this. But to be honest, we might fail the event super quickly because we might just fail to diagnose somebody correctly. If you fail to diagnose somebody correctly, then you immediately fail an event. Anyway, I'm not going to pay too much attention to it. I'm not going to pay too much attention to it. I'm gonna let it do what it does in the background. That's completely fine. I'm gonna focus on the much larger number of patients here. Patient is about to leave the clinic. You've already been diagnosed. You don't need anything else. Yeah, you just need this. Alright, fine. Alright, 18% of the patients have already been cured. That's only 2. Everyone has been diagnosed, though. That's pretty good. Have I found the absolutely optimal way of playing this game with just like a low level of certainty? Is that the way to do it? Malaria? Okay, this is not good enough. Okay, Frank Baker, you've been diagnosed with malaria. I do not feel confident enough to diagnose you with malaria. Frankly, I think you might have angina, to be honest, more than anything else. Right. I really don't even think that you should be in infectious diseases, but okay, you know what? I'm going to queue up a whole bunch of extra treatment for you just in case. I really don't think that you deserve to be there. Yeah, at least you haven't been treated yet. That's somewhat good news. How has this been the best attempt at an event that we've ever had? And this is when we give the least hoots about our patient. Okay, you are a high priority patient. Okay, everyone has been diagnosed. Everyone has been diagnosed with 100% certainty, with the exception of Frank Baker. Yeah, okay. So what we need to do is literally just focus on him and then hope that this is it. Okay, let's get you examined. Let's get you examined in here. Isolation, hospitalization, etc. You could still very, very much have something that is problematic. Suppressed heart failure. Suppressed heart failure leads me to believe that you've got something non-infectious diseasey. But you know what? As a precaution, we can keep you in isolation, hospitalization for a good long time. Let's give you an ECG, actually. Let's give you an ECG. Autopsy on Carol Lee's finished. Send you home. Brilliant. Yeah. Where's an ECG conducted? It's a cardiography unit. Fine. Hospitalized, waiting for a free examination room, and collapsing. I think this is going to be the end of this for us, I think. It's heart failure again. And there's still another fatal symptom to diagnose here. Yeah, I thought that would be the case. I'm almost certain that he had angina there. I think that we would have had that one. I think that just goes to highlight the risk. It highlights the risk of leaving the treatment options on low, because it means that somebody on a whim is sent to... That's fine. On a whim is just sent to, you know, isolation, hospitalization with very, very little evidence of what actually of what actually is wrong with them. Okay. I do actually want to see this autopsy. Oh, Linda Clark. You were... Where were you put into the hospital? Oh, you... An infectious patient wasn't hospitalized in an isolation unit. As a result, part of your hospital has been infected. A part of your hospital? I wish it was a part of the hospital, but unfortunately, it's the whole flipping hospital. Right, let's go up to pathology. I want to have a little look. Also, we seem to have capacity issues at the brain units. I don't think we have any beds in the... Yeah, we don't have any HDU beds in the brain unit. Yeah, that kind of sucks, but that's okay. What am I waiting for? I'm waiting for Frank Baker's diagnosis here. Yeah, can I get you seen to immediately? I'm like 90% sure that you've got angina, by the way. Like, I'm 90% sure. I'm 90% sure. How did we just narrow it down to 50-50? How did that happen? Transported to autopsy? Yeah, I know. We're waiting for it to happen. Waiting for the nurse to move the patient through. Performing autopsy, Frank Baker. Holy cow. Are these all the patients that you've got to autopsy? Oh my god. There we go. Alright. Myocardial infraction. I don't think that was an option. I don't think that was an option when we did it. Yeah, I knew it. I knew you didn't have an infectious diseases issue. I just knew it. I just knew it, and that's oh so unbelievably irritating. Life goes on limited. Well, the sad fact of the matter is that Frank Baker, the hospital failed you, and for that I am sorry. I am sorry. There is no redemption from that. But not only did the hospital fail you, the hospital failed itself because we failed an event, and that makes me grumpy, and I'm irritated with that. Anyway, you know what? We're going to succeed in an event next time. I am 100% sure. I'm very, 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 very sure that eventually we're going to get across the line. We're going to be able to do it. Ladies and gents, thank you ever so much for watching this episode of Project Hospital. My name, of course, has been Over the Potato. Thanks as ever to Banana Nana and C Senpai for being the two $25 plus tier patrons. Thanks also to, oh my god, another patient just died. Thanks also to just all the Patreon supporters over there who help make videos like this possible. It really is greatly appreciated. Oh boy, we'll be back for some more Project Hospital next time. I'll see you then. Bye.